Welcome to the PPA website. Here you can access a variety of resources related to the patient pathway analysis. If this is the first time you've engaged with the PPA, you're in the right place. This introductory video provides an overview of the PPA, why it exists, the methodology behind it, and example use cases for it. It features a presentation given by one of the PPA's creators, Dr. Christy Hansen. The presentation was part of a webinar hosted by the International Union Against TB and Lung Disease on April 18, 2019. Once you finish this intro video, feel free to explore the rest of the website to learn more or to start building your own PPA.
So today's session, we're going to explore the patient pathway analysis. In the session today, I will give you a brief overview of the rationale for this analytical methodology. And I'll turn it over to my colleague, Jesse Brown, to walk you through a semi-automated tool that you can use at country level to actually build a patient pathway analysis. So I think most of us are aware, people working in the field of tuberculosis are aware, that nearly 40% of people who have tuberculosis currently are not notified by programs, and we don't know if they are receiving or have received an appropriate diagnosis or appropriate treatment. And obviously, there's been intensive effort over the past several years to find what we call the missing patients, get them onto appropriate treatment, and have them notified. We certainly know from prevalence surveys that there are people with tuberculosis who may be asymptomatic or be early in their disease progression who are not seeking care. But we also know that there are many, many people with TB who are actively seeking care somewhere in the health system, and they're not being identified. To remove this burden of continual care seeking from patients, we see it as a priority to, at a minimum, find all of the people with TB who are somewhere in the health system, find them quickly, find them efficiently, and get them onto appropriate care. So to do this, we think it's really important to understand the alignment between how tuberculosis services are being provided today and where people with TB are seeking care. Because if these two pieces are not aligned, where people seek care with where services are available, obviously this leads to inefficiencies and can lead to multiple visits and a burden on patients. So the patient pathway analysis aims to understand this alignment. And we have learned that there are existing data in nearly every context to help us to understand these two facets of the patient pathway analysis, the patient care seeking and the service availability. So from the patient care seeking perspective, many countries have TB prevalence surveys. Others have published literature. There may be population-based surveys such as demographic and health surveys, even census data in some cases. On the service availability side, we know that many countries have done service availability assessments. Others have government reports or government plans, and there have been technical reports by partners that can help us to inform a knowledge base of service availability. When we pull these two pieces together, we can start to map on an aggregate level where people enter the health system, where TB services are available, and to better understand the alignment. Now, when we started this work, we thought it would be important to see to test the hypothesis that we could actually do patient pathway analysis using existing data sources in high TB burden countries. And so we set out to undertake the PPA in 13 countries that account for more than 80% of the world's, or nearly 80% of the world's TB burden. So I'm going to walk you quickly through the 13 country aggregate summary and then go into a country case example. So the starting point with the patient pathway analysis is understanding where people who at this point are symptomatic of having TB, eventually to be diagnosed with TB, where do they start seeking care when they feel ill? Nobody's a TB patient until we've determined they're a TB patient. So at this point, we're just talking about people with illness. So in the case of the 13-country study, what we see is that there's nearly equal use of the public and private sector in general. And there's also very important use of the informal private sector. And we got these data largely from demographic and health surveys. But it's not only looking at public-private mix. We also want to understand at what level of the health system people enter care. That's where we want to be able to link them immediately to tuberculosis services. So if you look in the brown columns on the bottom of the chart labeled level, you will see that 8% of all people seeking care for symptoms related to tuberculosis start at what we call L0. L0 refers to community level care providers. L1 is more of our primary health care service availability level. L2, we're starting to get to maybe the district hospital type of level. And L3 is the more advanced tertiary care level. Next, we want to look at now, how does that initial care seeking align with where we put tuberculosis diagnostic capabilities? And in this 13-country study, the only common diagnostic for which we had data was microscopy. So I'm showing you microscopy here to explain the methodology. What you can see is that, let's take in the public sector level 1, where 17% of people start their care seeking, only 43% of level 1 facilities have a microscope or a referral mechanism to get a specimen, a sputum sample, to a microscope. So more than half of people who start care seeking at level 1 in the public sector by default are going to have to go somewhere else to get a TB diagnosis. When we aggregate all of this, we found that in these countries, fewer than a third of people who are actively seeking care will encounter a TB diagnostic or even the potential for a diagnosis, a specimen collection and transport at their first point of care seeking. Similarly, we can map the same availability of treatment services for tuberculosis, and again, look at the aggregate of what this means. So again, about a third, less than a third of people access care where TB medications are available. This is important because we assume that the point of care, the facility at which people start their care seeking, they're indicating a preference. They're indicating that this facility is a place that is accessible to them, appropriate to them, hopefully affordable to them, and we certainly want to make sure that treatment is available at that preferred place of care. Obviously, you can imagine that when we have under a third of people accessing care in their first visit, they have to repeat visits. They have to go other places, they have to seek care again. And we know that this goes on and on multiple times until eventually a person is detected and notified and eventually treated. So what in this country summary it shows is that, unlike some of the global notifications that look at treatment success in terms of success among people who are notified, what we found through the patient pathway analysis is that it's fewer than 60% of people are notified, which is consistent with our global estimates, and that treatment outcomes, we only have slightly more than half of people being successfully treated in aggregate. Now, I want to take an example from Kenya to show a bit more detail and to move into thinking about how programs can use this information. So the example from Kenya is visually slightly different than the aggregate survey, and that was a preference from Kenya, and in large part because they had more data than we had at the aggregate level. So in Kenya, as you can see, there's important use of the public and the private sectors. And in this case, the Kenyan government wanted to differentiate their diagnostic availability in terms of capabilities to detect drug-sensitive TB compared to drug-resistant TB. In Kenya, we found that the access to a diagnostic technology, either microscope, X-ray, expert, or a referral to an expert site happened for about 44% of people at their initial point of care. Obviously, this leaves a lot of room for the Kenyan government, for the National TB Program, to try to resolve and bring capacity where patients are seeking care. The same for treatment services and treatment outcomes. Now what I want to do, this is at the national level, what I want to do with this slide is help you to identify some of the key gaps that emerge from this picture of the national pathway. So the first thing that we see is that with it's labeled A in the pathway visual. There is an important private sector in Kenya. About 26% of people with illness that could be symptomatic of TB start their care seeking in the private sector. The private sector has been engaged in some of the urban centers of Kenya, but certainly not all. And we see that only about 8% of people seeking care in the private sector had access to a diagnostic technology at their first visit. So quite a bit of room for improvement. In terms of the level, the category B, or the circle with a B inside, is helping to take a look at the private sector notifications and how those correspond to the availability of diagnostic and treatment services rather than the magnitude of the private sector in Kenya, which again, just highlighting the private sector gap. The second gap, really important gap that I want to highlight in C, is just overall what we call the diagnostic gap, that there's a misalignment between where people initiate care and where the diagnostic capacity exists. The most important gap is in the public sector at this level 2, where almost a third of people with TB symptoms enter care, and where less than 20% of those facilities have even a referral mechanism to a diagnostic capacity. So that's at the national level. You can imagine how the patient pathway analysis could be used by the National TB Program to identify some key gaps that may suggest that people who are actively seeking care within the health system are being missed, and where some small tweaks to the system, reallocation of resources, expanded availability of services could help to close the gap in terms of the people who are notified and found with TB. Now, I want to move really quickly. As you can imagine, we can program in a more nuanced way if we can bring the patient pathway analysis to a sub-national level. So in Kenya, the patient pathway analysis was actually repeated for all 48 counties. And I'm going to move quickly through these slides. And what I want you to notice is if you look at column 3 and column 5, which are the aggregation of diagnostic access and treatment access, I want you just to look at the nature of the difference between different counties. So I'm going to go quickly from Nairobi to Kisii, with Nairobi being an urban area and Kisii being a rural area, and look at the marked difference. This corresponds to a need to do highly differentiated planning, county by county, in the case of Kenya, maybe province by province in other settings, region by region in others, to use the patient pathway analysis as a way of reflecting the particular care-seeking tendencies and preferences of each community and the corresponding need to design our service interventions to correspond to patient needs rather than expecting people with TB to find the services. Now I'm going to turn over to my colleague, Jessie Brown, who is going to walk you through more of the mechanics of how to actually build a patient pathway.